Hello and welcome to the ARDS study notes. The topic of this note is the clinical evidence for low tidal volume in ARDS management. Before listening to this note, it is recommended that you listen to the overview of ventilator-induced lung injury and lung protective ventilation note. Low tidal volume is a strategy to prevent physical stretch injury due to hyperinflation in ARDS lungs. It recommends applying a tidal volume of 4 to 8 ml per kilogram of predicted body weight and limiting plateau pressure to less than 30 centimeters H2O. The clinical evidence for low tidal volume emerged in the late 1990s, with 4 major clinical studies published around the same time. Unfortunately, 3 of these studies reported that low tidal volume did not improve the mortality of ARDS patients, with one exception. However, in 2000, the ARDS Network's ARMA study demonstrated that low tidal volume reduced the mortality of ARDS patients, changing the overall perspective. The reason was that the ARMA study was significantly larger than the other studies. In the ARMA study, the lower tidal volume group applied a tidal volume of 6 ml per kilogram of predicted body weight and limited plateau pressure to less than 30 centimeters H2O, while the traditional tidal volume group applied a tidal volume of 12 ml per kilogram of body weight and allowed plateau pressure up to 50 centimeters H2O. The hospital mortality in the lower tidal volume group was about 31%, which was significantly lower than the rate of approximately 40% in the traditional tidal volume group. Additionally, the lower tidal volume group had a higher proportion of breathing without assistance up to 28 days and longer ventilator-free days. There was also a longer period without multiple organ dysfunction syndrome, and the concentration of the pro-inflammatory cytokine interleukin-6 was lower, indicating significantly better clinical and laboratory indices in the lower tidal volume group. Based on the results of this study, the 2017 Adult ARDS Mechanical Ventilation Guidelines recommended, with moderate confidence in effect estimates, limiting tidal volume to 4 to 8 ml per kilogram of predicted body weight and plateau pressure to less than 30 centimeters H2O for patients receiving mechanical ventilation. However, even when applying low tidal volume, it is impossible to completely prevent the occurrence of ventilator-induced lung injury. A study that observed 30 ARDS patients with low tidal volume applied by CT scan showed that in 20 patients, tidal inflation occurred in the normally aerated compartment, leading to protected tidal inflation. In contrast, in 10 patients, tidal inflation was retransferred to the already hyperinflated compartment, resulting in tidal hyperinflation. In other words, even with low tidal volume, ventilator-induced lung injury due to hyperinflation may occur in about 1/3 of patients. For this reason, there have been attempts to further lower the tidal volume. One of the representative pilot trials was the ExtraVent study, which evaluated the clinical effects of ultra-protective ventilation. In this study, the ultra-protective ventilation group was administered 3 ml of tidal volume per kilogram of ideal body weight, and arteriovenous extracorporeal CO2 removal was used to remove carbon dioxide in the blood that increased due to a decrease in minute ventilation. The study compared 40 patients in the ultra-protective ventilation group with 39 patients in the group using conventional low tidal volume. Among all patients, there was no significant difference in ventilator-free days and in hospital mortality between the two groups. However, in patients with severe hypoxemia with PaO to FiO2 ratio less than 150 millimeters of mercury, ventilator-free days were significantly longer in the ultra-protective ventilation group. Therefore, due to the potential for additional reduction of ventilator-induced lung injury, a feasibility and safety study on extracorporeal CO2 removal was conducted for ultra-protective ventilation. This study was called the Supernova study, which found that the use of extracorporeal CO2 removal to facilitate ultra-protective ventilation was feasible, suggesting the need for a randomized clinical trial to properly evaluate the effects of ultra-protective ventilation. Thus, the REST study, an RCT on ultra-protective ventilation, was conducted and reported in 2021. The REST study compared 200 patients in the ultra-protective ventilation group using extracorporeal CO2 removal with 205 patients who received conventional low tidal volume. However, disappointingly, the 90-day mortality in the ultra-protective ventilation group did not show any significant difference compared to the control group that received conventional low tidal volume. In conclusion, extracorporeal CO2 removal used to facilitate ultra-protective ventilation did not have an effect on reducing mortality in ARDS patients. As a result, there has been no significant progress in the clinical recommendation level for low tidal volume since the 2017 ARDS mechanical ventilation guidelines. Nevertheless, low tidal volume is the only strategy capable of reducing mortality in ARDS patients of all severities. So then, how extensively is the low tidal volume approach genuinely being adopted in clinical practice? The definitive effect of low tidal volume was first reported in 2000. According to the Lung Safe study, which surveyed the clinical field in the winter of 2014, 14 years later, the results were quite disappointing. In actual clinical practice, the implementation rate of low tidal volume was only 64%. In other words, more than one-third of patients were not receiving the essential management proven to reduce mortality. This is a disappointing result that calls for serious reflection and awareness among clinicians. This was the clinical evidence for low tidal volume in ARDS management. Thanks for your listening.